Hello everyone, my name is Justin Pierce, and on behalf of Azalea Health I'd like to welcome you to our June webinar. In this webinar we are going to be discussing best practices and strategies to navigate evolving payment and care delivery programs. This is going to be recorded and will be available on our website at www.azaleahealth.com under News and Events and Webinars. And I'd like to represent our two panelists here, starting with Justin Barnes. Justin's Industry and Public Policy Advisor, Chairman Emeritus at HIMSS, EHR, Co-Chairman Accountable Care, Community and Practices, and has addressed Congress many times on a variety of healthcare-related topics. Other panelist is Baha Zidan, Co-Founder and CEO of Azalea Health. So I'd like to pass the panel over to Justin Barnes, and we will begin.
Thank you very much, Justin, and I'm very excited to be here today. Appreciate everybody taking the time to join us. We know that you have busy schedules, but we appreciate the hour that you've given us today. And we will be sharing these slides out with everybody as well, so if you've registered, you will be getting a slide deck. We probably actually will share a couple of extra slides. There's a lot of content that we'll cover today. So I will apologize ahead of time because, again, there's a lot that we're going to pour through. We don't expect you to write everything down. Again, we will be sharing these slides with you. And we do these webinars about every 3 months. And so we're going to cover a lot of ground on all that's happened on Capitol Hill over the past 6 months and really what the future of healthcare holds over the next couple of years. And again, thank you very much for joining. So starting off with what's happened in the last 60 days, and that's the passage of the Medicare Access in CHIP Reauthorization Act called MACRA. And the biggest component there is, this is something that many of us have been working on for well over a decade, to replace the flawed sustainable growth rate, the flawed formula that offered cuts of anywhere from 10 to almost 30% a year to physician reimbursement and provider reimbursement. So we really needed to get some stability so providers, care providers across the country didn't face this glooming cut every single year. And again, many of us had worked on it for so long, so happy we got it through. It was a little bit shaky at the end there that we weren't sure if we were going to get it passed, but we did, and I think it's a great direction. It's a 3-year glide path, and I'm going to cover some of this in more detail coming up, but it's a 3-year glide path to get care providers, physicians, clinicians into new models of care based on value and quality. And we'll see a lot more of that be rolled out in regulation in the coming years. But I think it's a great path to either move towards some merit-based incentives or accountable care. And I'm going to cover all of that today. And then also, we're seeing a lot of evolution on the accountable care side. We expect probably it could be 50-50 or 60% of the care providers go for the merit-based system. That's closer to fee-for-service, and that's what the new system would look like. But then probably up to 40%, and maybe more, will go for the accountable care. Roughly 15% of care providers, maybe as high as 20% of care providers today practice in these new models, and they're comfortable with accountable care, and that's only continuing to grow as ACOs grow across the country. And there's a new shared savings program out there that's offered more flexibility in how ACOs are created and how they're managed, greater performance-based risk and reward, as well as use of innovation, such as telemedicine. And Baha, my guest, is going to cover some of that today. Very cool. They have the first electronic health record that has telemedicine and telehealth integrated into its product. But you're going to see a lot more of this. Really cool innovation around care coordination, telemedicine, telehealth. So, and even to that point, in Medicare this past January, there's now $42 per month that's available per patient to doctors that coordinate care for the chronically ill. So I think a lot of great evolution, and you're only going to see more of that. The new rules coming out, there's a lot of pressure on Medicare to continue to reimburse for telemedicine, telehealth, in more care settings, and at the same reimbursement as a visit today, not at a reduced rate. So I think look for that coming over the next 12 to 18 months around some of these innovations that we're continuing to see. And I'm going to cover a little bit on meaningful use. I mean, obviously, a lot of people don't want to hear more about meaningful use and want it to go away. And the good news is, with this new Medicare access, the passage of MACRA, this new act, meaningful use will phase out. The penalties of meaningful use will phase out. It'll still be important, but the penalties will actually be phased out after starting in 2019. So So still got to stick with meaningful use. You've got to use electronic health records meaningfully in these new programs that are coming out, but the penalties will be subsided. But you'll have other penalties if you don't follow and increase care coordination, increase your quality, increase the value in the clinical resources that you use. So it really does balance out in the long run. But today, 540,000 care providers are registered for meaningful use, and 460,000 have achieved meaningful use. So I was there in the early days when this was being created, helped create some of this legislation and regulation, and this is a great success from a standpoint of how many people are participating in the program. Now we're trying to, make sure that it's the best program out there, and we continue to ratchet it back just so care providers can clear the hurdles and continue to meaningfully use the technologies that they've invested a lot of money in. And over $31 billion in incentives has been paid to date. So a lot of growth in this program. And we still need to see a lot more from it. We need to see a lot more from the vendors to create the EHRs to be more usable. We need more interoperability amongst these EHRs, and you're going to continue to see all of that in the coming months and years. Now specifically around MACRA, and this is really a landmark change. Like I said, this has been in the works for 10 years. And the SGR, how all physicians and care providers are paid in the ambulatory setting, is going away in 3 years. So look for this. Again, so this new Medicare Access and CHIP Reauthorization Act of 2015 permanently repeals the SGR, reimbursement formula. And it establishes starting this year, starting in July, a 0.5% payment increase for all clinicians, and that is sunsetted in 2018 because you're going to start to transition over to these new either merit-based incentive payments system or alternative payment model, an APM. So you're going to hear a lot about MIPS, which is, again, the merit-based incentive payment system, or the APM, which is the alternative payment model. So those are the two models starting in 2019 that all care providers will be paid under in the ambulatory setting. And this is also occurring in the hospital setting. I'm going to cover that in a moment. But really, the alternative payment models are going to probably offer the most reward, because the MIPS is very similar to where fee-for-service is today, but it obviously is now all stabilized. There's no more cuts. There's actually increases. But you're going to have a lot more on the clinical resource, the clinical improvements, being based on your peers around you, regionally, not nationally, which is a good win. And then also, increase in quality that you're bringing to your community and to your patients. So that's going to be the MIPS program. The alternative payment models, a lot of that will still be flushed out, but I think the upsides that I see are much more generous to explore the alternative payment models, such as ACOs, such as value-based reimbursement, such as PCMH, patient-centered medical home, which Baha also will speak to a little bit later on. And as I mentioned, all of this, though, these penalties that were associated with meaningful use, with PQRS, and with value-based payment modifier, the VBM, those all get sunsetted at the end of 2018, because there's new programs that will be rolled out, have all those programs already implemented in them, so you don't need them to fall outside of the new systems that have been created. So specifically regarding the MIPS program, the merit-based incentive payment system scoring, 15% will be based on clinical improvements, so how you're increasing some of your patients around resource utilization, around quality, and specifically using meaningful use of your electronic health record. So we're going to learn more about these specific metrics in the coming months, 18 to 24 months, so it's ready in time for 2019. But these are really the systems. So 15% tied to clinical improvement, 30% tied to resource use and becoming much more efficient in your practice, around care coordination and what providers are used for what. Increase in quality, so 30% of your payment is going to be tied to increase in quality, and then 25% will be tied to the meaningful use of your electronic health record, and that's, again, a 100-point system if you add up all that. So that's really what the new MIPS program, and again, it's really fee-for-service put on steroids. And then the next system is going to be around accountable care and alternative payment models, but we will see that coming up in the next 24 months, what measures are specifically in those ACOs in alternative payment models. Now on the HHS side, specifically relating to hospitals, HHS earlier this year in January set goals of tying, and this is really where MACRA came from, this new Medicare Access Act, where it came from was they had a goal of tying 30% of fee-for-service Medicare payments to quality and or value through alternative payment models such as ACOs, PCMH, and bundled payments by the end of 2016, and tying 50% of those payments to those models by the end of 2018. And that's what you saw in MACRA, in that act. They implemented exactly what they foreshadowed earlier on this year, and they got it through Congress. So now, on the hospital side specifically, HHS has set a goal of tying 85% of Medicare payments to quality and value by the end of 2016 and 90% by the end of 2018. And that's really through the hospital value-based purchasing program and hospital readmission reduction programs. So this is occurring on every side of healthcare. So no matter if you're an ambulatory provider, an inpatient on the hospital side, these new models of care around value, increases in quality, increases in patient safety are all coming very, very quickly. And just to give you some perspective, in 2011, Medicare made almost no payments to providers through alternative payment models, but today, 20%, almost 20% of Medicare payments are made through alternative payment models. So as I mentioned earlier, we expect probably at least 30% to shift this direction by 2019, and maybe even a little bit higher. But I think you're going to see a lot of growth as physicians, and that's why we're going to hold these webinars on a regular basis so we can get to educate you on what's happening and how you can get involved in ACOs and alternative payment models in the future. And hopefully today, they're out there today. And to put this in perspective, in 2014, Medicare fee-for-service payments were $362 billion. So you're looking for seismic shifts over the next couple of years. $150 billion in payments. So it's going to affect everybody. And again, that's why we want to do this. We want to start moving people to look at ACOs. We want to start having people move to patient-centered medical homes, using innovations like telehealth and care coordination strategies. Those are all will get you paid more and perfectly position you for the future of healthcare. And just to show what we've seen, we just got a 2-year audit of the Medicare Pioneer ACO program, and the report came out at $300 per participating beneficiary per year in savings. So that's a lot of money, and that's terrific. So that's per beneficiary per year in savings, and that's so $300, not too bad. And again, these are just where they're starting. We're going to see dramatic increases in that over the coming years, but I think it's a good start. And this is just basically a graph of what I just went through. So if you look on the left-hand side, you're going to see 30% of fee-for-service by the end of 2016 tied to quality. And again, these are either ACO models, these are patient-centered medical home models, and then on the hospital side, 85% tied to these new models of care by the end of 2016, and then by the end of 2018, you're going to see 50% on the physician side and the ambulatory side, and 90% on the hospital side. So again, you're going to see just our point here, a lot of growth through, and this is not just, this is what the federal government is proposing, but the private sector is also right behind that, and that's what's here right now. So on your screen, 20% of provider payments in Blue Cross Blue Shield or Blue Cross insurers are through contracts that try to prioritize quality over quantity. And 28% of Azalea's reimbursements are currently tied to value-based contracts. And that's anticipated to jump 75% by 2020. And that would perfectly align where HHS is going. So again, my point here is everybody, no matter who you are, you can say, well, I'm going to get out of working with Medicare and Medicaid and switch over to the private payers. But everybody is going in this direction. So again, we appreciate you taking the time to join us because this is where the entire healthcare system is shifting. And so what does that mean? So here's kind of an evolution, and that's kind of we're going to switch over now to how do you get involved if you're not already participating in these models on the ambulatory side or on the inpatient side. What do you got to do? So hopefully you've all started and you've adopted. We have a lot of Azalea Health customers on the line, but we also have a lot of customers of other electronic health records. I read a report 2 days ago that 60% of providers out there that have adopted electronic health records are looking to switch. So they've achieved their meaningful use. Sometimes come hell or high water, they're not happy with the usability of those EHRs. So 60% of the market that own EHRs today are looking to switch. So a lot of opportunity to those electronic health records that are highly usable and highly functional and that offer tremendous support for their products and for their strategies. So a lot of, but key to this is EHR utilization. And like I mentioned up on the slide right here, training and usability are key. You've got to make sure that you rely on your vendor to give you the training and usability that you need in their EHR. And also that the vendor believes in interoperability and supports interoperability, because data has got to be shared throughout practices and throughout communities with hospitals and health systems. And then once you have the EHR adoption, you move up to meaningful use. And like I mentioned before, 460,000 providers across the country have achieved meaningful use. That's pretty strong, and have been paid incentives. So money is flowing out there, and it's a good base for building on where you need to be for the future, because you can't achieve value-based medicine increases in quality without using health IT, without using innovation, without using meaningful use. And even if you didn't qualify for meaningful use for one reason or another, use it as a playbook. It's going to perfectly position you for where the future of healthcare is going. An example of that is if you're on stage 2 meaningful use and you've achieved stage 2 with your electronic health record, then you're going to be perfectly positioned where patient-centered medical home is going, and all the incentives and payments there. And I think you're going to hear from Baha the significant increase in annual reimbursements that you can get when you implement a PCMH foundation in your practice, in your community, or an ACO. A lot of extra money available there. And both of those models, they're built off of where meaningful use stage 2 is today, but they perfectly position you where the future of healthcare, where all models of care are going tomorrow. And again, so here in the foundation, the next evolution is value-based medicine. That's what I've been talking about earlier, where all these human systems are shifting. So quality-based reporting, outcomes-based payments. There's over 700 accountable care organizations today. So they're all around us. You may not know about them, but they're around you. And it's very good to understand what you can participate in today. And I'm going to give you some strategies on how you can align, how you can best prepare your practice or your health system for participating in these ACOs. But they all are essential building blocks for creating a smarter and sustainable healthcare system in the country. So now to that end, what are these trends and how you can be best positioned? So focus on what HHS is doing. I just went through several slides on what HHS is doing and what all the major insurers are doing out there, and then obviously what MACRA, what that new act that affects the sustainable growth rate and takes that off the table. So look at what all this means to your practice, what it means to your future reimbursement, what it means for your reimbursement maybe later this year and starting in 2016. But health plans are all incentivizing patient behavior as well, so they're aligned with you in a lot of ways. They're trying to get patients engaged, their patients to take care of themselves better, use technology, use innovation, track their blood pressure, track their A1Cs, but track their entire health plans and know their numbers. There's, wellness visits are pretty much free across the board with most payers, if not all. And they want patients to know their numbers, and that's something I've been focused on personally, and hope everybody is, so you can continue to create. Because what this means is patients are paying more for their own health care. Most patients in the country pay more today for their health care than they ever have before. So they've got to start taking better care of themselves, because if they're continuing to drink, smoke, have unhealthy habits, obesity, not eat right, not what should they eat, they are going to pay more, I promise you. And probably everybody that's in an earshot of me right now is paying more. And if the only reason you're not paying more is because you work for a very large company that has been absorbing it, but they won't be able to absorb it much longer. They're going to start passing along those costs to everybody. But another thing to look out for is low performers are being pushed out of these alternative payment models. They're being pushed out. So when I say a low performer, that means a care provider who is a high utilization of services, who are not looking at resource utilization within their practice. They're not coordinating care. They're ordering duplicate tests. They're not promoting wellness checks for their patients. So they basically cost a lot. They're very expensive to operate and provide care. Those are considered low performers in the healthcare system, and they're being pushed out. They're being pushed out to private practice, and people say, well, that's a good idea. Well, very soon, if you're not part of a healthcare ecosystem where you're sharing data, where you're sharing results with other providers electronically, it could get much more expensive and difficult to practice care. And so that's why we want interoperability. We want high performers in our communities. We want these accountable care type organizations being created. And these communities are on the rise, But it's not. But you want to look at how your peers are performing. You want to benchmark your peers. You want to benchmark yourself and understand how do you perform regionally with your outcomes. And look at patient volumes. A lot of providers, they haven't looked at their patient volumes. Some have increased, which is wonderful. But sometimes there's a 5, 10, 15% decrease in patient volumes because you just don't know if an employer has switched all of their employees over to high deductible health plans. And next thing you know it, patients aren't going to see their doctors quite as much because they're paying for all those services, or they're paying the first $50 to $100 or $1,000. And so patients are making different decisions, and we want to make sure everybody's looking out for that. And also begin to push your payers for more transparency in their rates and transparency in their outcomes, in what their costs are. So understanding costs on the provider side, understanding costs on the payer side. Now I know the only people who have really opened it up are Medicare. They've done a pretty good job. They're working hard to have a lot more transparency in their numbers, but we want the private sector and the private payers to do that as well. And then also provide a risk-based education. Understand what it means to take on risk. If you're going to join an alternative payment model, and certainly an ACO, you've got to understand how much risk you can take on. And when I say that, that means if it costs you $180 for a specific office visit, but you're only going to be reimbursed $140 or $130 if you're going to go at risk, then that's not a good deal, because you could lose $40, $50 on that office visit, and nobody wants that. So your goal is to understand, yeah, I can take this office visit for $180, but I know that I'm going to be reimbursed at $220, so I can make at least $40 net profit on that office visit. And if I can do 100 of those a day, or 30, 40 of those a day per provider, then you're all right. Or say I'm going to be reimbursed $180, but only cost me $130 for that office visit. Well, those are all net savings that you get to take. That's $45 per visit. So that's how you can understand if you can take a risk or not in these contracts, because these contracts will give you a certain amount, and you just got to make sure that you can provide that office visit for less. And then running analytics, what data services do you have? And then also something that I've partnered with Azalea on this webinar is because they're phenomenal at revenue cycle management. They're one of the leaders in the country on RCM, and that's a critical strategy for navigating the future of healthcare. Certainly with ICD-10 on the way, with all these outcomes-based payments and value-based models that are coming, revenue cycle management is critically important to giving practices and hospitals the expertise that they need to take on contracts, take on new contracts. And again, with ICD-10 barreling down the path of all of us, I see revenue cycle as only continuing to increase. And that's why I've partnered with Azalea, because they're excellent and they're experts in it. But then also, another reason why I like Azalea is because of the virtual care strategies when they've done a telemedicine. So that's another piece here. And patients are comfortable with telemedicine. That's the part where many providers are not. We're trying to get providers more comfortable with it, telemedicine, telehealth strategies for communities. A lot of the rural markets have already moved towards telehealth just because it's a natural pipeline for healthcare. It's a natural pipeline for seeing patients and for getting into remote settings and offering remote care to patients who cannot go see a provider, don't have access to a provider. But also it's a great revenue stream for practices. And again, a lot of rural health have been much more comfortable in adopting telemedicine and telehealth. But now we're pushing Medicare more than ever to include it in all their ACO models, to reimburse at current rates that office visits are, and you're going to see continued growth in that area. But my bottom line there is patients are comfortable with telehealth and telemedicine. So, and they're becoming more comfortable every single day for these video chats and these telehealth. So just please look into it if you're a provider and understand what it means for you and what additional revenue it could mean for you. Now, when we look at some of these ACO models and these accountable care models, what are the most popular? Obviously, the Medicare Shared Savings Program that was launched several years ago is the most popular because it offered the least amount of downside. It offered the kind of least amount of upside, but it offers the least amount of downside as well. So a lot of people went for the Medicare Shared Savings. They also knew it was going to position them perfectly to where the future of healthcare is going, and so they kind of put their toe in the water, learned alongside the CMS and Medicare, and even Medicaid in a lot of these instances. So that's the most popular. The private ACOs are the second most popular, and that's where the private sector, and when I say private sector, I mean the private payers, it stepped up and helped create some of those ACOs in partnership with medical practices and hospitals. And then Medicaid ACO at 9.3, and then the CMS Advanced Payment ACO, again tied at 9.3. The Pioneer ACO is at 4.7. Those are really, that was for leading. I mean, I think there's only 31 out of the gate. And the reason why there was only 31 is because you really had to be an ACO operating kind of as an ACO for many, many years before that Pioneer program was rolled out. So those are for the very mature ACOs that had already been cranked up in the mid-2000s, in late 2000s, and it's just, I think there's only 31 to start off with. And about half of those, after the first couple of years, rolled over to be regular old shared savings program. So that's really the most popular ACO models out there today. And this report was just put out actually a couple weeks ago. So this is kind of the latest and greatest there. Now some of the best practices from a high level. And because my goal with this webinar is to begin, I realize that many of you may not have started down the path of PCMH or down the path of ACOs, and that's okay, plenty of time. But our goal here is to give you some of the best practices to make you more comfortable with exploring this. And Azalea offers those services, and we offer those services. But it's very important to begin to research what's out there and how you can kind of dip your toe in the water as well. So, but here are some of the best practices that have been published over the past 6 months to 12 months. As bonuses from shared savings flow to providers, they must be shared with the frontline staff as well. It's not just for the owners of the practice. It's not just for the clinicians. It's for everybody in the staff. It's for the practice administrator. It's for the billing clerks. It's for the schedulers. Everybody's got to be bought in to this new model of care. They've got to be bought into all the savings that can come along and additional incentives. It's not just for the providers of care. So very important that everybody gets to see these increases in financial incentives. And clearly define the criteria for creating these neural networks. It's very important that we kind of go through all the measures and people understand what needs to be achieved. I think some of the biggest issues in the early on where people didn't quite know what providers were best, how do you select a high-performing provider, and why they were so important, and what quality metrics did we really need to achieve, and educate them on how to achieve them. So really defining what your narrow network, what you're going for, and how to select the best care providers. So a lot of people just partner with, hey, I've been working with Dr. John for 10 years. I want to bring him into my network. Well, Dr. John may not have been the very best orthosurgeon or cardiologist. They just happen to be your friend. Well, that's not how you want to pick who's in your network. Again, you want high performers. You want people who are low utilizers of services but offer the highest quality of care. And this is where benchmarking comes in. Benchmarking regionally and locally, not necessarily nationally. And this is something that we've worked on very hard with CMS and Capitol Hill, is getting them to understand that we don't want benchmarks nationally because cost of care changes so dramatically, and it's very local. Healthcare is local, and we can try to stabilize some of that national sway, but we don't need to do that right now. We need to do our benchmarks locally and regionally to other care providers, and that's how they're going to create the new merit-based incentive programs and these new accountable care models. It's all based off of regional and local, which is wonderful. And also focus on EHR interoperability with mobile platforms to get patients involved. So you've got to share information amongst EHRs. You've got to share information with your local health information network. And obviously we've got to get patients much more engaged in providing their updates, because they're taking this data in. They're wearing these Fitbits. They're creating these portals, and they're doing this in conjunction with payers. They're doing this in conjunction with EHR vendors, and they're doing this on their own. And I think one of the biggest pushes that I've seen over the last even 2 months on Capitol Hill is getting the payers, getting the health plans, creating metrics and interoperability with EHR vendors in their portals. So what portals are being offered by the health plans, they integrate with the portals being offered by the EHR vendors, so patients can share data between these systems, which I think is very smart and needs to occur. And now there's much more pressure on the payers to do this. And gather data on patient satisfaction. People don't understand that 5 to 15% of future reimbursements in healthcare are going to be based on patient satisfaction. Again, it depends on what model of care you're going to be participating in, but a lot of hospitals, they're already paid on patient satisfaction today, but this is moving very quickly. It's already in accountable care models today, but it's moving very quickly into all of the ambulatory setting as well over the next 3 to 4 years. So understand patient satisfaction. It's during the normal course of business, and that collecting it is not a separate burdensome manner, that you actually can collect this through easy systems that have already been rolled out, maybe through your electronic health record. It can be done through some great innovations that are out there, but make sure patient satisfaction is top of mind. It's a great best practice. And also look for increased use of patient activation measures, which really are going to be getting patients engaged in not only their surveys, but then having patients manage their own care, and look to see how those innovations and patients managing their care can be integrated back into your care plans that you have for the patients, in your patients. So you're going to see, and they're called, again, patient activation. Patients are managing their information. They're much more comfortable with mobile devices and mobile platforms. They use mobility in every other component of their life except healthcare. So they're moving it into healthcare very quickly. You're going to see that coming up as well. So now, in the Medicare Shared Savings, they came out with some lessons learned, and I like to cover this. So importance of strong clinical leadership. That means getting the providers all aligned, understanding what measures you're going for, and that everybody's incentivized to get to those specific measures. Communication and transparency. So this is across the board. Communication in what measures what measures you guys are going for. Communication in care plans, continuity of care, communication amongst all the care providers, transparency of what people are doing, transparency in how providers measure up with each other, what benchmarks each other have, and also practice redesign is very important. This is not about practicing medicine as you have the past 20 and 30 years. There's a lot of redesign that's going to occur. There's a lot of best practices out there that can be shared and allow you to redesign your practice. And again, when I say practice, not just ambulatory setting, this is obviously for the hospital and inpatient side as well. It's just a practice of care is what that means. And innovative care coordination. So coordinating care, 5 years ago is very different than coordinating care today and coordinating care in the future. It's using technology, innovations such as telemedicine, using analytics, and interoperability of data so you can share information amongst your care providers internally as well as externally. The value of looking at data and understanding data in dashboards. There's some great products out there. A lot of EHRs that offer these components internally, and there's products out there like Wellcentive that offer great products externally and can pull in data from all across the spectrum of your community to give you the data visualization you need to hit the quality measures, the increase in quality and increase in patient safety that you have to hit to get paid on. And don't attack this all at one time, and again, this is why we like these webinars. We're going to continue to do them quarterly, is pick a few things to improve on and build on the success. So don't try to tackle, again, every single measure. You can begin tackling a couple at a time and maybe work to CMS or what your private payers are offering and tackle them and get your practice kind of aligned, again, inpatient and outpatient. I'm going to spend a few minutes over on consumers and patient engagement because this is not all about what the care providers need to do. We are pushing very hard to get patients more engaged in their healthcare, patients, again, to know their numbers, to take their healthcare seriously, to try to eat better, create better healthier lifestyle, make better choices in their lifestyles, and they're doing it. They're slowly doing it, but they're doing it. But you're going to continue to see mobile health be a significant component to your patients' lives. And so find ways to embrace that, enable that. There's money in there for you. There's certainly cost savings in there for the patient, and cost savings from a standpoint of annually on hopefully their premiums will potentially decrease, really stabilize, but also their health and quality of life. So mobile health is certainly here to stay, and patients believe it's intrinsic to their healthcare moving forward. But just give you some examples of what is happening out there. Patients are self-measuring, they're self-monitoring, and they're self-managing, all through mobile health and mobile devices. 500 million patients globally are expected to access a mobile health app by 2016. and I don't think providers realize this. And if they do, they're not asking, and they may not be engaging their patients. But patients are the cheapest resource you have in your practice. They will give you information. You tell them to come in there with blood pressure results and tracking all that. They can do that without giving you these expensive devices to take off. These devices are very cheap out in our communities. We can go buy them, $30, $40. They're very accurate. I use one every single week. I take all my results, I put them all into my medical record, electronic medical record, and patient portal that my doctor offers me, and I have this very symbiotic and a fantastic relationship with my provider of care. All my providers of care, actually. And it's a great experience, and they embrace mobile health. And so just understand that patients are doing this, and they're doctor shopping. And then and again, this is why I want you to understand how your patient volumes are reacting potentially to this. Do you see an increase in patients? Have you seen a decrease in patients? Have you seen an increase in patients that you want to see? That's very important because there's a lot of different pay patterns out there. There's a lot of different reimbursement models out there. So a lot of doctors that I work with strategically, we work together to find how can we go attract the patients that they want in part of their ecosystem to increase their reimbursements. You know, not everybody, there's a lot of strategy there, and understand that you might be left with the rest instead of having the best types of patients. So understand that patients are doctor shopping, and they're actually doctor shopping through their devices. It's kind of cool. But they're seeking pricing. They're seeking patient satisfaction of how providers, what kind of care providers offer, how satisfied are their patients. They're looking for board certifications, and then again, patients are going to come to you with, it's called PGHD, patient-generated health data. If they haven't already, patients are going to come to you with all their information and go, hey, I want to import this, or at least offer it to you. I've been tracking my health data for 2 years now, and I want what I've been tracking at least visible to you. You may not want to put it inside your electronic health record for one reason or the other, but they at least want you to see their blood pressures. And whatever it is, they want you to be a part of their care plan. It's not just what you're doing. It's, you guys are going to kind of be, you know, partnered now through portals, direct messaging. There's a lot of opportunity out there. So now I would love to turn this over to Baha for some of his innovations and expertise. So Baha, the floor is yours, my friend.
Wow, thank you, Justin. What a great content, and can't thank you enough for providing our audience with such a great wealth of information. It's very important for us to really keep track of that, and we're honored to have you as a guest and to allow us educate our audience again with all of this information. It's sometimes it feels overwhelming, but like we were discussing that earlier, those are laws that have been passed. So it's not something futuristic. It's not a dream. It's reality. And one of the things that we're seeing in this reality is ICD-10. And one of the things I was able to do real quick online, I found a business days calculator, and we only have 69 business days left for October 1st deadline. At that point, Medicare will turn in all their claim acceptance. We'll have ICD-10 and a CPT code. So it's only around the corners, and this time we're going to pass pretty quickly. So I would, if I was a provider or I'm in the healthcare administration side, I'll make sure that my providers are familiar with ICD-10, familiar with their crosswalk. They don't need to learn all the 100+ thousand ICD-10 codes. They just need to play within their sandbox and understand within their specialty. And there's all kind of tools online to allow the providers to basically take their ICD-9 codes and translate them to the ICD-10. And we provide some of those, actually, some of those resources on our website. So feel free to go to azaleahealth.com under resources, and there's plenty of links in there to help you with that. One of the things that we advise our users, of course, is start asking your vendors how ready they are. A lot of vendors are providing test tools now, and I tell also a lot of our customers and users, follow the ICD-10 trail. Sometimes we don't realize ICD-10 not only in the chart itself, but it's in the lab order, It's in a lot of places. It's if you have a little tool that does the crosswalk for medical necessity checking, well, it needs to be ICD-10 ready. So make sure that you have all your ICD-10 systems or ICD systems are ICD-10 ready. One of the things that Justin has touched on is the patient-centered medical home. There's a lot of wealth of information in that side, and with accountable care organizations is more of a larger version of the patient-centered medical home. And Azalea Health has been always focused on the smaller physician offices and the rural physicians, and that's one of the things that we see there's going to be a huge advantage for our providers who will adopt patient-centered medical home. Why would a primary care physician want to participate and be a patient-centered medical home facility? It really is simply better for patients. He or she will have a more engaged patients with their care coordinators, and of course more satisfied patients will create additional business. We're seeing some studies show that about 11% in increase in revenue for practices that are becoming patient-centered medical home. So it's important, and also overall, a patient-centered medical home, the premises of patient-centered medical home is lowering the overall healthcare costs. We're going to see less patients going to the ER when they're coordinated with their team and checking with their nurses and their care providers to make sure they're sending them to the right channels. One of the things that patient-centered medical home is, the center of that is the patient, and it's a comprehensive care. Patient-centered medical home facilities provide prevention, wellness, acute care, and chronic care, and that's very important for the patient. Also, it's, as I mentioned earlier, it's patient-centered, but the coordination of care enables a lot of communication. Where if we look back just a few years ago, healthcare is silos. It's, the cardiologist doesn't talk to the primary care doesn't talk to the neurosurgeon, and there's nobody talking to anybody. With patient-centered medical home model, the care coordination and the passing the information is essential. And of course, with that, accessibility to data and electronic health records is a core of that. But at the end of the day, patient-centered medical home facilities, they have to show quality and they have to show results, and you have to have systems in place to track that quality, track that results, and make sure that you are actually providing additional value to the patient. Last thing I wanted to talk about is the telehealth. Telehealth is also I've spoken to physicians who've been working on some telehealth initiatives in 1992. I didn't hear it before internet. So it is a reality. It's very important that we see a lot of physicians who are intimidated by telehealth. They're going to lose those patients who want to be engaged with their providers remotely. We're seeing more and more insurance plans providing telehealth numbers, where basically a patient can dial a number and for a refill, and simply talk to a provider who is licensed in their state and allowing them to get a prescription as quickly as a phone call away. With Azalea Health, we are integrating the telehealth as part of the workflow of the electronic health record. The electronic health record not only manages the patient record, but it manages the workflow in the physician office. And we feel telehealth, it will become, and it's becoming more and more as integral part of the workflow of the current and future physicians. We're excited about the telehealth. There's a lot of benefits for telehealth, from patient engagement and the ability to access the providers anytime, the ability for a rural provider and a rural patient to access a specialist in an urban area. This is going to be great. We're excited about that, and we're looking forward to continue to innovate in that and continue to provide additional workflow processes around face-to-face and telehealth visits. I'll turn it to Justin to also elaborate more on what we've been discussing.
Yep. And also, I failed to mention in the beginning that we do have a full question and answer pane. We're going to get to a Q&A section here very shortly, but I think there is a pane for if you have any questions. We'd love to get to them in a moment. And again, we will be sharing this slide deck. As Baha mentioned, this is a lot of content. I do understand. We have already had a couple of great questions. I noticed that one of the questions was, what are the measurement tools for the new MIPS program? And we don't know yet. We only know that some of the 4 buckets, but that's going to be created over the next 18 to 24 months. So we don't know the criteria yet for the MIPS program. We don't know the exact measurement tools. We don't know any of that yet. That's all going to be defined over the next 18 to 24 months, really in time for, and it probably might even take a little longer than 24 months, because it's got to be ready by the end of 2018. But the reason why it has to be ready a little bit sooner than that is because we have to go integrate that all into the electronic health records too, all those collection tools. So it'll be, so anyhow, that's the answer to that question, is they're not quite ready yet. So now, before we get over to Q&A by everybody, and I look forward to that session, I'm going to just go through some best practices and what you can do, because I mean, again, I've been doing this for so long. I've worked with hundreds and hundreds of practices and hospitals across the country to position them to successfully navigate the future of healthcare. And so I know how stressful sometimes these conversations can be. People feel like, my gosh, all these changes, I just want to get out. You know, well, what I'm going to do over the next couple of slides is kind of say, what can you do in the next couple of steps to make this, you know, this transition easier and to give you kind of the confidence to begin to embark. And that's why I wanted to have Baha here, and I'm glad that we were able to partner, because very important in this journey is finding the right partner to navigate. So you've got to use the right health IT. You've got to have the right support structure to buy that electronic health record vendor. You've got to have the right training and support. You've got to have services like revenue cycle. You've got to have innovations like telehealth. You've got to have expertise and how all these new models are going to evolve. And so that's just critically important to success as you navigate further into the future. So here, my first bit of advice is utilize health IT to increase your care coordination. Focus on using the EHR, and then if you can't use it or you don't quite understand how best I can help you, contact your vendor. See what solutions and services. I know Azalea is about to roll out a whole PCMH strategy at another level here, and I'm very excited about that. So go push your vendors, whether it's Azalea, whether it's whoever it is, if you're switching, go push your vendors for support that you want and that you need to be successful. And hopefully you will begin to look at PCMH. You will begin to go look at ACO models and any alternative payment models, because they're offered today. This MIPS program, that's coming in the future, but there's so much available today. Like I mentioned, there's 700 ACOs out there today, and every payer in the country offers care coordination incentives, offer PCMH types incentives. They all offer them today, so you can begin to explore. Understand how important interoperability is. Push your vendors. If your data needs to go somewhere, tell your vendor where your data needs to go and work with them on that. Understand your beneficiary volume in your organization, because you got to kind of understand what your patients, you know, what your patients can take on, what kind of care coordination, what type of quality increases, but really understand your beneficiaries, because you're going to have pools large enough. I mean, you can't take on some of these new models of care with the insurers if you've got 2,500 patients. You probably need to have 5,000, 10,000 on a certain plan. So you got to understand your beneficiary volume to work effectively in these new models and to find out what's available to you. You can partner with local practices. I've done dozens of these now where I've brought practices together in communities to get them to bring together the beneficiary models so they can bulk up to, say, 10,000 patients on a single plan, because then you're going to have a lot of negotiating power and opportunity with these payers, whether it's CMS or whether it's the private payers. And then look at organizational structures and understand that, hey, maybe you do merge, maybe you don't merge. I've created medical villages where everybody still operates independently, but they do share patients and they do share plans that they work within. And it's a phenomenal opportunity to increase revenue today and to be a part of where the whole healthcare system is going tomorrow. So just consider new organizational structures, not just staying solely independent and planting that flag And you can, again, you can stay independent, but with interoperability, sharing patients, sharing data, I think you'll benefit tremendously. And identify, again, what CMS, Medicare, Medicaid, commercial, combined care coordination, ACO opportunities are out there. Every health plan in the country today, in every single community, offers new care coordination and new opportunities to increase cash flow if you're going to coordinate care and increase value and increase quality for your patients. Every payer does. Whether they've offered it to you, that's a different story. So it's very important for you to go to your providers, your payers, and ask them, what do I qualify for? Or even if I don't qualify, what are my opportunities? And because then you can go change your patient volumes or your beneficiary volumes or something, or partner with somebody to qualify for a new model of care. But you probably, if they aren't offering it to you, they're offering it to somebody in your community, and you're probably competing against it. And so I'd recommend asking what's available in your community. And as I mentioned earlier on, having transparency, understanding the average cost for an episode of care. Medicare is sharing their cost data. We're inquire with your commercial payers as well. They're slowly beginning to share this information, but we're pushing on them very hard, so they will open up the kimono there and share these costs. So, because if you can actually know what an episode of care costs you, you can begin to take on risk, you can negotiate contracts better, and you can find out how much profitability you have in every single visit. That's critically important. I mean, I've run companies, and that's how I run my own life, is you don't buy something that you know you can't afford or you can't go at risk to pay for. So it just continue to down that quest. And again, as you know, knowledge is power when negotiating with payers. So, and looking at your healthcare ecosystem, so assess your relationship with your community, with your peers, with your medical associations, with your payers, employers, and health systems. Employers are so critically important to our communities because they are shifting patients. They are shifting how patients make decisions, how much patients have to pay for their health care because they're employees of these employers. And these high-deductible health plans do shift a lot of decisions in our communities. I've already mentioned benchmarking yourself against regional and national peers, certainly regional peers, and understand how you rate in outcomes and cost. Understand how your organization creates the best network of providers out there. How do you look for not just your friends, but the highest performers? Ultimately, you will care who's in your network because you want the high performers, not the high utilizers. Evaluate interoperability. I've already kind of beaten that drum pretty heavily. And just don't wait. These ACOs and accountable care models in these at-risk communities are forming all around the country. And they're available really to everybody if you get out there, sniff around, and find out what's available. And again, this entire presentation is for ambulatory as well as much as for the hospital side. So in this slide deck, again, we're going to share this with everybody. There's additional links that you can go out there and look at what CMS is doing, the Innovation Center. CMS offers a lot of educational events. They're always free. I recommend you take them up on it. And also, I like this, the third one down in the top section, the innovative maps and models. It shows what's happening in every single community across the country, certainly what CMS is doing, but they also do show some of the private payers, I believe. But then look at what HHS is doing in these new payment models, so I linked to that there in the bottom. Medicare provider utilization and payment data, who's getting paid what, that data is continuing to grow every single day. And Medicare Physician Compare, that is a patient-focused transparency website that shows what providers participate in what program, what quality program, meaningful use, PQRS, e-prescribing. And so patients can make more informed decisions to go see the most advanced care providers in the country today. That's consumerism at its best, and Medicare is flying in that direction. And that link in the very bottom link will point you right to that. So now we're going to shift over to everybody's questions. Justin, go ahead and start, my friend.
So we had a couple of questions come through. Justin addressed one to date already regarding myths. We also had a few just more general questions. I think, Baha, earlier you had a discussion on ICD-10. Really directly to what is actually going to happen on October 1st, in your opinion?
Well, simply, if you're sending a claim with ICD-10 to Medicare, you'll get paid. And if you send a claim with ICD-9 instead of ICD-10, it'll get denied. So that's as simple as that. But you also want to realize that some payers are not going to be ICD-10, and they were not going to accept ICD-10. for example, check with your vendor. We have a feature in our system where by payer you could set the default if they're accepting ICD-9 or ICD-10. So you want to make sure that October 1st, if the payer accepts only ICD-10, you want to send that in that format. If they want to accept only ICD-9, you want to send it in the ICD-9 format. But simply, if it's not done correctly, it's just going to be simply denied.
Yeah. And I've been on Capitol Hill a lot lately, and I don't see any changes. I see ICD-10 flying down the path. I don't see any delays. There's a couple of bills floating out there that might say, hey, we can maybe calm down some of these rejections. But again, that's getting blasted because people they're ready for this transition. Care providers have been investing in this transition for 2+ years now. All the vendors have been, investing in this transition. Everybody's, they're pushing, and they just got to kind of bite the bullet. So I don't see any changes to ICD-10. That train's barreling down the path. So, any other questions?
Sure. Yeah. Follow-up question to that. Actually, we talked a lot of the evolving payment and care delivery programs. One of the questions that came through was, when do you think all of this is going to happen?
Yeah, I get that a lot, and I think there's a lot of skepticism. But and I think even Baha mentioned this again when he spoke. This already occurred. All this legislation was passed and regulation was passed this year. So on the ambulatory side, you've got the SGR will be gone by the end of 2018. You'll either have the merit-based incentive payment system being rolled out, or you can go for the accountable care, the APM side. You got to go for one of those two directions. So that's the ambulatory side. On the inpatient side, they're already moving down the path with readmissions and new value-based purchasing. So in patient satisfaction, they're flying in that direction on the inpatient side. So this is all passed. This train is, again, barreling down the path. And this has been 10 years in the making, so it's here.
All right, great. Well, I think we have expired our time today. We appreciate you sharing your time, and I want to personally thank Justin and Baha for sharing your insight, and it's very educational, this discussion. Again, this webinar, Best Practices and Strategies to Navigate Evolving Payment and Care Delivery Programs, will be posted shortly on the Azalea Health website. Again, that's under News and Events and Webinars. We also have additional slides that will be posted, some additional content, as Justin mentioned, so please check that out. Again, thank you for your time, and until next month.
Yeah, no, thank you. Oh, yeah, and actually, Baha will be my guest coming up here in a few weeks on my radio show, so I look forward to that. And then again, as Justin Pierce mentioned, there's a lot of good content here, and if you want to follow me on Twitter at HIT Advisor, please do so. And as Justin mentioned, you'll be receiving these slides as well, and probably a little additional content. So thank you very much, everybody. Appreciate your time.
Thank you.